Hello, everyone, and welcome to another audio podcast. In this series, the Storm Robotics case review of v.2, and this is an audio podcast relating to the British Transplantation Society, or the BTS, and it's a review of science in around between 2003 and 2016, and the this is the Shientist, and it's another audio podcast under the Storm Robotics production. And what I thought I'd do in this audio podcast is provide a little bit of an overview relating to the British Transplantation Society, or the BTS, from around 2003 to 2016, and generally every or annually the British Transplantation Society have an annual sort of remit or conference in relating to highlighting aspects that pertain to different areas, different aspects of transplantation medicine. And this in this audio podcast, I thought I'd provide a bit of an overview around the BTS, British Transplantation Society, in context of its scientific sort of bases from 2003 to 2016. So to begin with, I thought I'd highlight about what the BTS, what the British Transplantation Society is generally all about. So to begin with, so the British Transplantation Society is a non-profit professional body representing the community of physicians, surgeons, nurses, allied health professionals, and scientists involved in organ transplantation in the United Kingdom. The British Transplantation Society supports the provision and dissemination of medical research in organ transplantation, and also develops national guidance and policy in the provision of transplant care to patients, including living donation. Notably, the society supported the debate for what has been known as presumed consent from deceased donors in the United Kingdom, in United Kingdom Parliament, and also for the use of donation after circulatory failure in the expansion of the donor pool. And so, in line with this, and as part of the remit, it was in 2000. It was in the early 2000s that the conference remits had where the British Transplantation Society have various remits in relating to different areas of practice surrounding organ donation and organ transplantation. Now, it was in 2000. It was in 2004. 2003, 2004, the British Transplantation Society developed guidelines relating to solid organ transplants from non-heart beating donors. It was in 2005 the British Transplantation Society developed United Kingdom guidelines for living donor donor kidney transplantation. In 2005, it also the British Transplantation Society also developed guidelines for liver transplantation in patients with HIV infection. It was in 2008 the British Transplantation Society developed guidelines for living donor kidney transplantation in high-risk adult patients. It was in 2010, between 2010 and 2015, the British Transplantation Society developed guidelines around management of post-transplant lymphoproliferative disorder in adult solid organ transplant recipients, along with in conjunction with and jointly with the British Society of the British Society of the British Society of Immunology and Transfusion, I believe it is. It was in 2010, between 2010 and 2015, the British Transplantation Society developed guidelines with between 2010 and 2015, the British Transplantation Society developed guidelines around diagnosis of post-transplant, with jointly with BSCH. Diagnosis of post-transplant lymphoproliferative disorder in solid organ transplant recipients, and it was in August 2010 also that the British Transplantation Society developed guidelines on post-operative care of the kidney transplant recipient, and it was also in 2010 that the British Transplantation Society with another organization developed consensus guidelines on organ donation after circulatory death, and it was in between 2011 and 2014. The British Transplantation Society developed guidelines assessment of the potential kidney transplant recipient, and it was in 2011 the British Transplantation Society developed guidelines around UK liver with the UK Liver Transplant Group around recommendations for alcohol-related liver disease, and in 2011 the British Transplantation Society developed clinical guidelines practice. It was in between 2011 and 2015 that the British Transplantation Society developed guidelines around living donor kidney transplantation jointly with the Renal Association, and in 2014 the British Transplantation Society developed jointly with the British Society of Histocompatibility and Immunogenetics a guideline on the detection and characterization of clinically relevant antibodies in allotransplantation. And it was in 2014-2015 there was a guideline or an addendum where the British Transplantation Society developed guidelines around living kidney donor guidelines, also in 2015 the British Transplantation Society developed guidelines for kidney transplantation with patients with HIV disease in around July 2015. All of these guidelines, by the by, are available through the British Transplantation Society website, and I am going to now talk a little bit about the British Transplantation Society in its current remit, and basically between 2016 and now in 2022, the remit around the British Transplantation Society has been heavily focused in and around looking at guidelines and practices in relating to specific sort of how to tackle specific donation specific organ donors organ donors that had, for example, been suspect or risked, or have been at high risk for example, EBV, or EBV or Epstein-Barr virus, and also in relating to the in relating to hepatitis E virus. So there was actually, in 2016, the British Transplantation Society had a remit where there was a sort of a perspective where one of the former medical directors for NHS Blood and Transplant, James Newberger, Dr. James Newberger, was highlighting some context around the hepatitis E virus. Before I get into that, though, I am going to provide a little bit of background in context to sort of the general sort of outline of this particular conference remit in relating to a review of science. So the one of the presenters at this particular conference, who represented NHS Blood and Transplant, talked about the trends in trends in deceased organ donors and transplants, and also the initiatives to increase deceased donor transplantation, alongside the examination of transplant center organ offer and declines. The speaker, the presenter, talked about living donation trends and latest results from living donor sharing schemes. Another presenter talked about the different sort of the sort of trends, the sort of analyses around deceased donor kidney waiting lists as of 31st of March 2009 to 2014, and it was in generally there was in the data set that this particular speaker who represented NHS Blood and Transplant at the British Transplantation Society had highlighted that there was more than for those who are waiting more than 7 years, waiting for more than 7 years for a transplant, for example, would be where for example there would be so the number on the active transplant waiting list in 2016, and around 2016, for example, would in between 2008 to 2009, 290 from 2008 to 2009, 200 and seven about so the data had highlighted that 296 patients were waiting for organ transplantation for more than 7 years. 282 have been waiting between 5 and 7 years, and then 1,000 1,029 have been waiting between 3 and 5 years, and 2,984 individuals have been waiting between 1 and 3 years, and 2,599 have been waiting less than 1 year. In 2009 to 2010, the number of those waiting for a transplant were over 7 years were 335 individuals, and then 325 between 5 and 7, and between 3 and 5 years 1,147, and between 1 and 3 years 2,908, and between or less than 1 year was 2,468. So that was between 2009 and 2010. In 2010 to 2011, 337 patients or individuals were waiting for a transplant more than 7 years. In between 5 and 7 years, 352 patients or individuals were waiting between 5 and 7 years. Between 5 and 7 years, 1,146 individuals were waiting for between 3 and 5 years. And between 1 and 3 years, it was 2,757 individuals between 1 and 3 years, and between less than 1 year, 2,279. So that was between 2010 and 2011. In 2011 to 2012, it was 349 patients individuals waiting for more than 7 years, 373 between 5 and 7 years. In between 3 and 5 years, it was 1,127. In 1 to 3 years, in 1 to 3 years, it was 2,553. In less than 1 year, it was 2,231. So that was from 2011 to 2012. In 2012 to 2013, it was 347 who were waiting more than 7 years. 345 between 5 and 7 years. 1,028 between 3 and 5 years. 2,339 between 1 and 3 years, and 2,289 or less than a year. In 2013 to 2014, it was 328 who were waiting for a transplant more than 7 years. In the same year, 278 were waiting between 5 and 7 years. In between 3 and 5 years, it was 818 individuals, and between 1 and 3 years, it was 2,121, and finally between less than 1 year, it was 2,336. That was from 2013 and 2014. In the generally deceased donor kidney waiting list as of March 2009 was that the highest waiting time was actually between 1 and 3 years. 1 and 3 years, where between 2008 and 2009, 2,984 individuals were waiting, and the data set that this particular presenter highlighted at the British Transplantation Society in 2016 was highlighting that for more than 7 years, of those who are waiting more than 7 years for more than 7 years for a renal transplant, the wait time for more than 7 years had actually increased up to 11%. Those who were waiting between 5 and 7 years actually had dropped by minus 1%, and by between 3 and 5 years had dropped between minus 21%. Those those were waiting between 1 and 3 years had dropped between minus 29%, and those who were waiting less than a year had been waiting at less than it had been the change of data had been less than 10%. So the biggest change was actually at minus 29 between 1 and 3 years, and so on average, the data highlighted that on average, when someone is waiting for a transplant, is the average time is average time, and irrespective of ethnicity, irrespective of gender, average time is between 1 and 3 years. So that's average. And generally throughout the data set, for example, the data highlighted that between 1 and 3 years, it would always the data always showed by this presenter at this research in the work that they did with and presented in 2016 at the British Transplantation Society, highlighted that the number of individuals that were waiting between 1 and 3 years would be above 2,000 individuals. So, for example, again in 2008, 2009, it was 2,984. In 2009 to 2010, it was 2,908. In 2011 to 2010, 2011, it was 2,757. In 2011 to 2012, it was 2,553. In 2012-2013, it was 2,339, and in 2013 to 2014, it was 2,121. And so the a couple of the questions that came up from this when this work had been highlighted at the British Transplantation Society conference remit in 2016 was, who are the long waiting patients? And so 98% are what are known as highly sensitized patients. So those who are, from a scientific standpoint, is those who already have antibodies, previous antibodies that would be propagated if they were transplanted, so thus to cause acute transplant rejection, and so 98% of the patients or individuals would be highly sensitized. 40% are those from the Black and Asian minority ethnicities. 45% were from blood group O. 32% were from blood group A, 18% from blood group B, and 5% were from blood group AB. 96%, and this is the most shocking out of all of this data in some context, is 96% are age 30 and over, and so basically those who are waiting on the transplant list are not necessarily the older people, despite in some contexts the contrary, where for example where presenters have highlighted in the Renal Association, and formerly known of Renal Association, the UK Kidney Association, UKKA, formerly known as the British Renal Society, where presenters have highlighted in research at the British Renal Society in different over different times, where basically that that it's the older people are more probable or likely to have or fall into chronic kidney disease, when this data from NHS Blood and Transplant highlight that actually 96% are age 30, and age 30 isn't particularly old. So it's age 30 and over, and so those who are waiting for transplants, for example, are actually getting younger in some respects, and so that is actually, in some contexts, it's worrying. So that's 96%, almost 100% are age 30 as an average and over. So that's worrying. That's concerning. And only 40% are actually from the Black and Asian minority ethnicity, where 60% actually relate to other ethnicities, and that's also worrying. So this presenter then said, as part of some of the context that they had, was 26% fall into patients with patients who are on deceased donor waiting lists over 7 years. So 26% will fall into patients on individuals on the deceased donor waiting list over last 7 years, over last 7 years, but 11% increase in long waiting patients between 2009 and 2014. At the same time, long waiters are highly sensitized, and this presenter at the British Transplantation Society had highlighted that long waiters are highly sensitized, and highlighted that was, in some contexts, it was specific to those from the Black and Asian minority ethnic adult populations. At the same time, a change introduced on the 3rd of September 2014 to give absolute priority to long waiters in the kidney allocation schemes, which reduced the number of long waiters on the waiting list by 18%. At the same time, still a build up of 100% sensitized patients. So generally those long waiters, according to the data, had highlighted that those who are waiting longer are more sensitized, owing to potentially antibodies from an immunological sort of standpoint. And another point was where this presenter highlighted at the British Transplantation Society conference in 2016, highlighted that living donor strategies were starting to develop transplant highly sensitized patients, but other strategies were still needed. So, for example, delisting. Some of the questions that came out from this work were from the work where the presenter highlighted delisting of unacceptable. Should we be delisting? Should transplant teams be delisting of unacceptable antigens? Another question was, another question related to antibody incompatible transplants, and another question was absolute priority for 100% sensitized patients. Should they be getting priority? And then at the same time, another point was that there should be another review, a broader review of kidney allocation. And in 2016, this presenter from the speaker at the conference at British Transplantation Society highlighted that there is a kidney allocation scheme that was sort of underway. Now, there was some data that came out from the National Organ Retrieval Service, and generally the National Organ Retrieval Service, or NORS, is a vital part of transplantation, of the transplantation pathway. It provides a national 24-hour service for retrieving organs from UK deceased donors, and based at major transplant units, and usually able to reach donors less than 3 hours. One of the speakers, this was a different speaker, presenter at the British Transplantation Society in 2016, representing again the representing NHS Blood and Transplant, and they highlighted that for example, around the UK region, there are 8 abdominal teams, there are 5 cardiothoracic teams, and there is 1 multi-organ team. And generally, the presenter at that time was highlighting some specific data around the National Organ Retrieval Service. I'm not going to highlight too much around that. Only suffice to say, with the context that I just provided, that is the basis of NORS. There was some data that came out from another data set from one of the presenters from another presenter from NHS Blood and Transplant, where they talked about organ utilization rates. So, for example, where this presenter talked about organs, basically organs from actual deceased donors, donor age criteria, whether it's been met, consent for organ donation, organs offered for donation, organs retrieved for transplant, and organs that are transplanted. And the data highlighted that in relating to organs, in relating to the organ utilization rates and deceased donors, in relating to deceased donors, around 80% are relating to kidney in relating to a percentage, it relates to the percentage of offered organs that are transplanted. So 80% was highlighted in relating to those who are awaiting kidney transplants, 36% relating to liver transplants, 27% relating to pancreas, and 11% in relating to lungs. And so I'm now going to talk a little bit about the main sort of plenary that sort of came out from the British Transplantation Society conference remit. And actually, what I'm going to mention here kind of relates to some reflections around COVID-19 and the pandemic. One of the plenary at the British Transplantation Society in 2016 was about something that's referred to as the Hep E virus or hepatitis E virus, and the former director for NHS Blood and Transplant, Professor James Newberger, talked about hepatitis E virus for transplant clinicians, and he talked about basically where HEV or hepatitis E virus has a natural history. There's a natural history. Has different genotypes, and basically generally stems from hyper endemic in the developing world, where it's waterborne, from infected, for example, infected water, for example, and it can be severe in pregnant women. It can cause it's an increasing issue in Western, apparently an increasing issue in Western Europe and the United States. And its main transmission is orophycal. So basically, where for example, transmission is through orally, by in some contexts by contamination, and also there is a link to eating pork, wild boar, and venison. And so Professor James Newberger highlighted at the British Transplantation Society sort of the natural sort of etiology of the hepatitis E virus, and in this he also highlighted, for example, that in works that had been published in 2014 in the journal of Hepatology, by an academic, Berendt and team, in 2014. They highlighted that hepatitis E virus needs a incubation period of around 40 days. The virus can be in blood for 3 weeks, and so it can remain in the blood for 3 weeks. The virus can remain in stool or feces for 2 or more weeks, and it may also be found or identified in urine. There's an asymptomatic there are asymptomatic or mild symptoms as well. So jaundice is included, but it's rare. It's quite rare, except in where there has been some evidence in those who are immunosuppressed, in some contexts, and there is susceptibility to reinfection, although there is some susceptibility to reinfection, but the data around that had been quite unclear, and there was some other context around this where there is sort of extra hepatic features of hepatitis E virus infection. So those included, from a neurological standpoint, is where basically patients can present with Guillain-Barré syndrome. There may be neuropathy, there might also be myopathy, and there may be swelling in related to encephalitis. From a renal standpoint, there is membrane proliferative glomerulonephritis that's linked to hepatitis E virus and nephrotic syndrome. and also in relating to other symptoms, other symptoms and other areas. There's arthalgia, there's rashes, there can be pancreatitis where there's inflammation around the pancreas. There's thyroiditis, and there's also low platelets and high lymphocytes. And there are some cases that had been highlighted in publication in some publications relating to HEV, hepatitis E virus. The presenter, Professor James Newberger, also highlighted some specific diagnoses relating to the serology aspects of hepatitis E virus. So, for example, there was from a serological point, there was IgM, immunoglobulin M, and immunoglobulin G or IgG anti-HEV may be unreliable in immunosuppressed, and there was works published by various authors who looked at IgM and IgG and hepatitis E virus in immunosuppressed patients, and there was hepatitis E virus and ribonucleic acid. It's not always reliable, as different platforms, different ways of investigating through laboratory, through pathology, are not always reliable, because the techniques are not synonymous between one laboratory and another, and so in context of where hepatitis E virus has sort of penetrated to the extent where patients have suffered from hepatitis E virus being bloodborne, where patients or individuals have been affected, where there's viremia evident, which is the virus has affected the hematology of individuals. And so Professor James Newberger highlights some data around this in relating to the rates from blood donor studies. And so some of the data includes, for example, in France in the year 2012 to 2013, one in 2,218 patients or individuals had what was known as ribonucleic acid positive. They were RNA positive for hepatitis E virus within hematology being affected. In the Netherlands, there were affected cases between 2013 whereas one in 1,761, and in 2011 to 2012 in the Netherlands it was 1 in 2,671. In Germany it was in Germany in 2011 it was 1 in 1,240, and in Scotland between 2004 to 2008 it was 1 in 14,520. In England in 2012 to 2013 it was 1 in 2,848. In other data, there was predicted. Professor James Newberger highlighted predicted transmissions from blood components, and this was data from an organization known as SABTO, and where SABTO had reported that with particular blood components. So for example, red blood cells, platelets, fraction frozen plasma, etc. There was a number of blood components that were sent out or used in relating to predicted transmissions of predicted transmissions from blood components. So let me repeat this. Where blood components, red blood cells, platelets, fraction frozen plasma, where potentially at the time, the predicted transmissions from blood components from those who potentially required blood transfusion, blood components from those who had donated, potentially, the data set highlighted where in 2013, for example, over 2,621,000 units across different blood components where there was with those blood components there was predicted transmissions of hepatitis E virus, and there was in the data set there was predicted infections from exposure. So in total, those who had been infected through transmission, through potentially having blood components, out of all of the data, 368 individuals may have been infected with hepatitis E virus through potentially from predicted transmissions from blood components. Now, aside and from that, there was data that also highlighted the prevalence or the probability or likelihood that those who for example are transplant recipients who have had transplants and who potentially could have HEV, hepatitis E virus. Generally speaking, it was between in liver, in those who had liver transplants, the prevalence was low, between 3 and 5%, and data highlighted was particularly around the Netherlands and Germany. And then those who between those where there was prevalence, whereas a medium sort of prevalence between 5 and 10% were based in Sweden, around Sweden, and those where it's high or most high or more than 10% was France and Canada. And from kidneys, when related to kidney transplantation, the prevalence in recipients, it was between 6 to 16%, and where it was specific more specific with IgG, IgG related conditions, and there were at the time, Professor James Newberger was informed that there were reports being developed in relating to lung, heart, and pancreas transplantation as well. There is data here where there was where they said where Professor James Newberger said had highlighted that the risk of infection from blood components at time of transplant was actually actually low, and typically so for example, in those who have for those who have liver transplants, the lower estimate of probability of clinically significant hepatitis E virus infection was 0.122%, and the upper estimate was 0.140%, and the transplant activity between 2014 in that given year for liver transplantation was 900. And so in the data set there was data that Professor James Newberger highlighted in liver, kidney, lung, heart, pancreas, intestinal, multivisceral, heart and lung, kidney and pancreas, kidney and heart, kidney and liver, allogenic stem cell as well. So generally speaking, the data highlighted that that across transplantation, the risk for anyone developing hepatitis E virus had been low. However, that being said, in the kidney transplantation group or cohort between 2013 and 2013 and 14, and specific to the United Kingdom, 3,055 individuals or patients who had been transplanted in that time potentially would be at that viable would be viable in some context, since the data at the time was highlighting the risk of infection and the probability of clinically significant hepatitis E virus. Although in relating to the probability of clinically significant hepatitis E virus, the lower estimate was actually lower than all other organ transplant groups. For example, where in kidney it was 0.006% at the lower estimate, and at the upper estimate it was 0.007%. And so the SABTO guidance highlighted that hepatitis E virus had been an increasing problem, especially in those who are immunosuppressed. However, it may be transmitted. It could be transmitted by blood products, organs, and so it was Professor Newberger at the time highlighted that it's important to use screen sort of approaches for blood and products as recommended. And the major risk, and this was one of the big sort of things, main points that came out from Professor James Newberger's presentation at the British Transplantation Society in 2016 in related to hepatitis E virus, was highlighting that the major risk is from diet, and especially in pork. So dietary advice and understanding to individuals was important. And on top of that, the impact on recipients is actually unclear, but it's linked with cirrhosis, and then significance in there is some significance in normal and abnormal liver function tests. And the final point was where Professor James Newberger highlighted that it's important for professionals to consider hepatitis E virus infection, potentially trying to offset any issues where immunosuppressed individuals or patients could be at risk of hepatitis E virus, and it would be important to treat them with there was a particular drug or treatment, which is known as ribavirin, where applicable, and so there were other, at the British Transplantation Society. There was other presentations in context of a transplantation in the United Kingdom. Another presenter highlighted have we gone too far in terms of organ quantity over quality, and it was someone known as Chris Callahan, who was a consultant transplant surgeon at Guy's Hospital in London, and there were also poster presentations. One of the ones that I thought were quite intriguing was about immunosuppression tapering for BK virus. Allograft nephropathy is not associated with increased risk for rejection or death-centered allograft failure. There was also a poster presentation around a systematic review of the quality of outcome reporting in immunosuppression trials in renal transplantation. There was also a poster presentation in relating management of recurrent atypical hemolytic uremic syndrome after adult kidney transplantation, despite eculizumab. Eculizumab is a monoclonal antibody form of treatment and used in prophylaxis. And so this team from Central Manchester University highlighted some of the context around that. And another poster presentation was the outcome after kidney transplant in patients with chronic hypotension in hemodialysis. There's a team from Guy's and St Thomas in London, and another team in Guy's and St Thomas in London had a poster presentation around sort of the psychological benefits after living donor kidney transplantation, and another team highlighted a presentation around deceased organ donation, important recent developments regarding consent, and there was another research poster presentation from a Scottish team that talked about careful deselection of unacceptable human leukocyte antigens and can facilitate renal transplantation in highly sensitized patients. Another research poster presentation was clinical relevance of preformed immunoglobulin M, IgM, HLA donor-specific antibodies in HLA-incompatible kidney transplantation, and generally the British Transplantation Society did have a remit around pediatrics as well. There was an overview on for example, when one presenter from the United Kingdom talked about the birth of neonatal donation and transplantation, and talked about how there had been sort of current limitations in pediatric donors in pediatric donors from those who are aged 0 at neonate for up to 2 years old, and some current limitations around that. And then from a kidney transplant from small pediatric donors, there's the presenter highlighted some challenges and anxiety. So, for example, where pediatrics patients would have small nephron mass, there would be dysplasia or malformation of kidney tissue, and that may be difficult to assess in neonates and infants. There may be proteinuria after transplant. There may be hyperfiltration injury and glomerulosclerosis. So glomerulosclerosis, scarring of the kidney, around the kidney, and there may be increased risk of vascular thrombosis. There may be increased risk of ureteric complications. In addition, there may be deceased donation. Deceased donation can pose sort of additional risks. There can be difficulties around procurement around that, and it can be tedious bench work. And from a laboratory medicine perspective and serology perspective, it is quite monotonous, irrespective of pediatric or adult kidney transplant donors, or donors from donors or adult or from adult donors. The laboratory medicine aspect is generally can be quite monotonous. And there's also where the presenter at the British Transplantation Society talks about the actual implantation of an organ from a pediatric donor can technically be challenging as well. And so there was also at the British Transplantation Society, there was an overview from sort of a best practice donation and sort of turning thoughts into action. And the presenter talked about sort of a living donor kidney transplantation, sort of UK strategy from 2020. The 2020 strategy was documented in this framework, and it was to increase living donor kidney transplantation to 26 million per patient per million population, and generally the guideline highlights a more in depth sort of strategy points, where the guideline is actually available from NHS Blood and Transplant as well. And there was an overview around the National Institute for Health and Clinical Excellence, or NICE, and their sort of document around immunosuppressive therapy for renal transplantation in adults. And it was a document that was sort of a sort of a review from where it was when NICE developed this document, this framework in around 2004, and one of the presenters at the British Transplantation Society was highlighting some reflective points around that. And finally, there was generally other presentations. Another presentation came from Dr. Simon Ball from the Birmingham the Birmingham team who talked about living donation. How do I get the best outcome for my patient? And he was talking about patients with non-ideal living donors. There was a presentation from a consultant transplant an organ retrieval surgeon based in Wales, Dr. Mike Stevens, where he talked about live donor transplantation for patients not deemed suitable for deceased donor transplant. And there was presentation, an overview related to human leukocyte antigen antibody testing. So there was talks about deceased donor cross matching and serology, and sort of the advances in laboratory medicine, for example, around flow cross match and Luminex technology, Luminex single antigen assay. So where Luminex is an assay that looks to detect antibodies which bind to beads and determines the human leukocyte antigen specificity of the antibodies, and wherein in Luminex technology, if for example there's individuals who have had previous transplantation through Luminex technology or through Luminex assay techniques, generally from implementing Luminex, it is possible to see and identify that previous antibodies and the titer levels around previous antibodies that could affect transplant actually can the memory cells from an immunological standpoint actually can through Luminex assay cannot and do not always pick up or detect those older antibodies that could prompt and propagate a transplant rejection response. So the advances through Luminex technology have actually advanced quite substantially. And so and also at the same time, how can we one of the questions that one of the presenters at the British Transplantation Society had talked about was how can we predict the cross match? So there's what are known as CDC panels or serological investigations. There are other cross matches that can be performed, cross match investigations that can be performed, and investigations that relate to potential living donor and deceased donors. A couple of the main conclusions that one of the presenters had highlighted at the British Transplantation Society was to remove. It's important to remove unacceptable human leukocyte antigens and sort of where the speaker highlighted that especially those unacceptable ones that are associated with the low risk of rejection and associated with the greatest likelihood of a transplant offer, and at the same time maximizing the chance of a successful transplant, and accepting an appropriate quality kidney in context of kidney transplantation, and providing excellent post-transplant care. So there were other presentations as well. There was a presentation in related to altruistic donation, altruistic donation, and preemptive transplantation, as well, and one of the main presentations at the British Transplantation Society conference in 2016 also focused on do kidney transplant recipients care? Do they care where their organs come from? And it was a presentation that came from Dr. Stephen Bond from Cambridge University Hospital NHS Foundation Trust, and one of the main things, or a couple of the main things, were that females that one of the generally from Dr. Stephen Bond's presentation, there have been works that have been published and have highlighted some of the context, but a few points that had been pointed out by Dr. Stephen Bond's presentation at British Transplantation Society was that that generally in relating to the particular question, females are more risk averse than males. Younger patients aged 18 years to 34 years are more risk averse than older recipients. Recipients with a history of cancer are wary of donor-derived cancers, and recipients previously transplanted are less likely to accept a dual transplant, a second transplant, or a subsequent transplant. And when given the choice, potential kidney transplant recipients are willing to make decisions on the types of donor organs they wish to receive. Again, there are works that have been presented by various other presenters. Yes, there were various other presenters, and since the conference in 2016 around the British Transplantation Society, this year, since then, there have been more guidelines and more frameworks around different areas of transplantation practice. In 2022, the British Transplantation Society will be having its conference remit in Belfast, in Belfast in the United Kingdom, and the remit is like others in context of scientific practices, and just to also say that in relating to the 2016 conference, where Professor James Newberger highlighted quite a lot of context around hepatitis E virus, the 2022 conference at the British Transplantation Society will potentially be highlighting some context in relating to COVID-19 and how that has caused sort of challenges across different areas of transplantation practices in relating to sort of the surgical challenges when individuals are called in for a transplant, alongside in relating to where there may have been there would have been challenges in aspects of organ retrieval owing to COVID-19 COVID-19 sort of restrictions in and around different areas of healthcare practice. So generally the British Transplantation Society has various sort of will have various updates in relating to the review around different practices and around the science, and I am now going to draw this audio podcast to a close. Yes, I'm now going to draw this audio podcast to a close. And once again, this has been the Shientist. This is a audio podcast in line with the ZtormTronix case review v.2. This is an audio podcast as part of the Storm Lobostics. A part of the Storm Lobostics production on the British Transplantation Society, the BTS, between 2003 to 2016, and it's been a review of the science, a review of science. Thank you for taking the time to listen, and hopefully catch you on the next one.